Good evening, ladies and gentlemen. Today, I'm very glad to be here to present a case report of laparoscopic pyelolithotomy in a horseshoe kidney. I'm Dr. Liu Haitam from Urology Department, Jarak Hospital. This is my outline 5 parts. Horseshoe kidney is the most common congenital renal function anomaly with a prevalence of 0.25% in individuals because of urine retention and crystal aggregation resulting from renal structure anomaly. Conculi becomes the most common complication of horseshoe kidney with a reported incidence ranging from 21 to 60%, and 95% of horseshoe kidney are fused at the lower points. Horseshoe kidney is one of complicated case for stone management, especially large stone in this type kidney is quite tough. Management of stone in horseshoe kidney, including open surgery, laparoscopic surgery, PCNL, RIRS, or robotic surgery. The vascular supply to horseshoe kidney is varied from many patterns. According to Krebs, there are 6 patterns. And the most common pattern observed was type 5, 28%, and type 6, 24%. The least common pattern was type 4, 4%, and type 3, 3%. The vein is very different. Therefore, parents in this parent we can see two IVC here, and in this parent we can see the IVC is in front of the isthmus of the horseshoe kidney. And horseshoe kidneys are anatomical abnormalities associated with stone formation. Advances in shockwave lithotripsy and endourological surgery have significantly decreased indication for open or laparoscopic stone surgery if percutaneous approaches are not likely to be successfully, and or if multiple endourological approaches have been performed unsuccessfully. Often or laparoscopic surgery may be a valid treatment option. In 1990, first laparoscopic transperitoneal nephrectomy was performed by Graf Kleiman. Since that time, laparoscopic procedures have become an essential and necessary part of urologic practice. In 1994, the first study describing the outcomes of laparoscopic pyelolithotomy in patients with Stockholm conculi. In 2004, first-scale use of laparoscopy to manage stone in patients with horseshoe kidney. Currently, improvements in laparoscopic instrumentation and techniques and surgical experience have made laparoscopic surgery a promising alternative for stone treatment in horseshoe kidney. Many reports state that laparoscopic lithotripsy was reported as a promising technique for stone, and in horseshoe kidney, the indication for division of the isthmus of horseshoe kidney are controversial, and if done, it during the concomitant removal of additional defects accompanying horseshoe kidney. According to EAU Guideline 2021, few studies have reported laparoscopic stone removal. These procedures are usually reserved for special cases. A few studies with limited numbers of patients have reported using robotic surgery in the treatment of urinary stone. If percutaneous approaches are not likely to be successful, and or if multiple endourological approaches have been performed unsuccessfully, often or laparoscopic surgery may be a valid treatment option. According to AUA Guideline 2019, open laparoscopic or robotic surgery should not be offered as first-line therapy to most patients with stones. Exceptions include rare cases of anatomic abnormalities with large or complex stone or those requiring concomitant reconstruction. A small number of case series, prospective trial, and one meta-analysis suggests that laparoscopic or robotic pyelolithotomy offers a reasonable alternative to PCNL or URS in this complex patient. The aim of this study was to evaluate the result of transperitoneal laparoscopic pyelolithotomy and mastectomy of horseshoe kidney. This is a 74-year-old male patient with a diagnosis of left kidney stone, infected hydronephrosis kidney with double J stent and horseshoe kidney. The patient had the symptom of left flank pain, and his vital sign is in normal range. His BMI is 23.8. The patient history in November 2020, he had the symptom of high fever, left lung pain, and dysuria. A diagnosis infected hydronephrosis, left kidney stone, acute kidney injury in horseshoe kidney, antibiotic, and left side double chase. Then the patient recovered after 5 days treatment. His urine analysis showed that leukocyte 500 and his urine culture E. coli with ESBL positive. In this antibiotic gram, the bacteria resist to many groups of antibiotic, including carbapenem, fluoroquinolone, and cephalosporin. In this KUB, we can see that a large radial park stone here and multiple stone. In this CT scan, we can see the isthmus is in front of the aorta and IVC, large pelvic kidney stone and multiple stone in some cases. The patient have high stone burden. So we decided to do laparoscopic surgery. The patient was put in a lithotomy position, remove the reverse double J, play a new double J, and put a polite catheter. The patient is placed in a 45-degree left decubitus position with slight flexion of the operating table to extend the ipsilateral flank strongly under general anesthesia. 2 12 ports and 2 5 ports were inserted as shown in this picture, and carbon dioxide were insufflated into his peritoneal cavity to create pneumoperitoneum. Mobilization of the descending colon. The left ureter and the isthmus of horseshoe kidney were identified. Ureter with double chase then was in front of the isthmus. Exposed the left renal pelvis is quite tough to detect because of inflammation and adhesion of perirenal fat. The pelvis were open and the stone was removed. Large pieces of stone was placed in the bed and retrieved. A small fragment was sectioned out. Cavity edges were sutured with 405 grain, as shown in this picture. In this picture, we use an endoGI vascular stapler for the division of the isthmus. As shown in this picture, the isthmus here and after cut to separate parts. A trend was inserted and all ports were closed. The total operative time was 4 hours and estimated blood loss was 20 ml. The pulse of KUB show is on small stone free. In this patient, mobilization and oral nutrition were included on the first day. The second day, removed trend. The fifth day, folate catheter removed, discharged from the hospital. There were no complications either during or after procedure. No blood transfusion, no fever. The laboratory tests show that no difference between creatinine, hemoglobin, and hematocrit. This technique of hemostasis is a major problem during laparoscopic procedures. Study have reported cases of non-functioning horseshoe kidney heminephrectomy with use of bipolar coagulation, microwave coagulation, harmonics cable, ligature, and endostapler for division of the isthmus. The ideal solution to completely avoid bleeding seems to be the stapler, but this use is possible only in the case of a narrow isthmus. Isthmusectomy may be a useful alternative measure to allow repositioning of the kidney and maintenance of an unobstructed upper urinary tract. In conclusion, laparoscopy is an alternative to open surgery, particularly in the correction of congenital defects of the urinary tract. Although the indication for division of the isthmus of horseshoe kidney are controversial, laparoscopic technique in isthmusectomy is safe for patients as shown by our result. The cosmetic result was much better than open surgery. The recovery time was significantly shorter than open surgery. Thank you for your attention.